patients between the age of 12 and 49 years. Can you start off and tell us a little bit about what was going on in Seattle and what inspired this study at that time?
Sure. Well, actually, for me, the story goes back a little bit farther. I was a medical student at USC, which was based at that time at LA County Hospital, and the chief of orthopedics was Paul Harvey, and there was 2 staff members for a total of 12 residents, so a total of 3. So Tillman Moore and Mike Patsakis were with J. Paul Harvey, and as a student interested in orthopedics, I used to go to the grand rounds, which were every Monday, during which the chief residents would present a series of cases. And on one Monday night, the topic was femoral neck fractures, and the chief resident produced 5 cases of displaced femoral neck fractures in patients starting at about 30, and then with every decade or 2 all the way up to 70, and asked the 3 attendings on every one of these cases what should be done for this, and the answer for all 5 was an operation called a muscle pedicle graft, which for the younger members of the audience has fallen out of disfavor. It was an operation that was described by Judet in the 50s. Basically, you put the patient prone on a fracture table, and you do a reduction of the fracture closed and put multiple Hagee pins, which is a pin with a nut on it that you screw in under power, 4 pins or so, and then you osteotomize the insertion of the quadratus femoris on the back of the trochanter, a bone plug 1 by 3 centimeters, and you free it up, and then you rotate it 90 degrees. You make a little trough in the femoral head, and then you put a screw in the back of the femoral neck. And the idea was that you would revascularize, quote unquote, the femoral head by this muscle pedicle graft. So the reason why it didn't work was that, number one, you're doing closed reductions and trying to hold it with multiple pins, and the reductions weren't good. And number 2, there's no way to swing that pedicle without getting the lateral epiphyseal complex off the medial femoral circumflex. So basically, by trying to preserve the blood supply, you're kinking the blood supply to the femoral head. So it proved to be a failure, and there were multiple publications. One of the early efforts of the Orthopedic Trauma Hospital Association before the OTA was to compile a series of over 100 of these that Dick Kyle compiled from the 8 members of the predecessor of the OTA. So that's the background. So I'm a resident at University of Washington, working at Harborview as a G2, and I get a call to go down to the ER to see a 62-year-old that'd fallen off a scaffold with a displaced femoral neck fracture. Dr. Sig Hansen was on call, and he got him on the phone. He said, "What do you want to do?" And I said, "Muscle pedicle graft," and he laughed out loud. And I've described this experience as the one which has driven me into the academics, because it never set well with me that 1,100 miles to the south, it's the answer for every femoral neck fracture. 1,100 miles to the north, it's a joke. So there has to be, one has to be right. So that got me into discussing this phenomenon with Dr. Hansen, and we did an open reduction via the Watson-Gillen interval, because that was the standard there, started by Bob Lindquist and Stig Hansen in the late 60s, early 70s. So I began to do chart reviews to look at the outcomes, and this publication was the chart review done on the younger age group and how they turned out with open reduction and screw fixation. So that's the background. It's a cohort series with all the problems therein, selection bias, although I don't recall any direct selection bias, there still must have been to some degree. That's the story behind it.
And so you commented on a few of the ways these patients were treated. Pretty much everyone got a capsulotomy. Fixation was cannulated screws, and the Watson-Jones was utilized for the open reduction.
Yep.
You had 3-year follow-up on most of these patients, I think about 90%, and no non-unions, 20% AVN. Do you
Yep.
think we've made any progress?
No, I don't think we have. And it's because in this age group, I don't think we have. A lot of these patients had very high energy. I can remember one of them was pushed out of a 3rd-story window, a young woman, and she developed post-traumatic osteonecrosis. If you get enough displacement at impact, you actually shear the lateral epiphyseal artery complex. So you basically have a completely non-vascularized femoral head that is going to revascularize through the trabecular and the neck. And eventually you're going to get resorption in the weight-bearing area and collapse. And one of the things that this study, this cohort taught me was that in some cases, the collapse occurs after 3 years. And the other thing that it taught me was that in general, if patients aren't having any pain in the run-up to the long-term follow-up, they're probably not going to develop it. But if they have continued pain, particularly groin pain over the years, despite normal-looking radiographs, eventually it's going to collapse. So the reason why it's 20% is that I think that's the group where the actual blood supply was sheared off during high energy trauma, or we got to them too late, and it was really the intracapsular tamponade effect that obscured the blood supply through that vessel complex.
In your current practice, is everyone getting a capsulotomy, and what is your typical fixation device?
Well, I'm no longer practicing at level 1 center, so when I see patients on the rare occasion they let me still take call, I would always open the capsule for any fracture. And this is an area where we have not been able to move the needle. Most practitioners in the OTA don't believe in the intracapsular tamponade phenomenon. The last survey I can remember, it was only 30% would consider an open reduction or a capsulotomy. But the thing I always ask when discussing this in large audiences is if you don't believe in intracapsular tamponade, how is it that you get post-traumatic osteonecrosis in a non-displaced fracture in 10 to 15% of cases? So there's no other mechanism, and I've done a lot of basic research in rabbit and pig models to show that with intracapsular pressure, you can obscure the blood supply of the femoral head as measured by laser Doppler. So yes, I would do a capsulotomy if it's a relatively non-displaced fracture where you don't need to do a open reduction to assure accurate reduction. I would still place a 15 blade along the anterior femoral neck and do a fluoroscopy controlled capsulotomy rather than an open reduction. So I hope that answers the question.
Yeah. What about fixation device?
Oh, right. I still would use multiple screws. That the manuscript which we're discussing, we didn't have cannulated screws in those days. We just used solid screws, and we actually at one point developed a jig so that we could put parallel 3.2 millimeter drill bits and get the screws parallel. So with cannulated screws, that's become a lot easier. So I would use 3 screws for most of these.
For physiologic age cutoff for fixation versus arthroplasty, any advice or insight that's maybe changed over time as arthroplasty is more common, but any role, 50-year-olds, 60-year-olds for fixation of a displaced femoral neck if they're physiologically that age as well?
In my mind, yes. I think that our field of orthopedic surgery has been heavily influenced by the meta-analyses, um, which has shown that when you're looking at RCT data, that the failure rate for internal fixation in patients above 65 is a high 30s, 33, 37%. In the FAITH trial, which Dr. Bandari and I did, multi-center, multinational trial, the failure rate was only 24% with more accurate reduction, but it is still 24%. So the way I think I would recommend that people make decisions is taking a history. If the patient is very active, let's say they're my age, nearly 70, and still, riding a bike 3,000 miles a year and doing resistance training and doesn't have renal failure or anything like that, I would want my femoral neck fracture fixed. And if the patient is not very active, barely a community ambulator, diabetic with multiple medical problems, that's the patient that should have the arthroplasty. And you can debate hemis versus total hip. The health trial, which Dr. Bandari and Dr. Einhorn led, showed no difference at 2 years for the monopolar versus total hip. But of course, that study needs the 10-year follow-up on what's most advisable. So the answer is, for a healthy younger person, I don't see an upper age limit. Have a go at internal fixation. It's still going to work out, in worst case, 2/3 of the time.
Yeah. I'd want my femoral neck fixed as well.
Yeah, you're not anywhere close to 70, but and you would want to choose your surgeon too, as would I.
What do you think is the most important question that still needs to be investigated for these injuries?
Well, if I had something to say about the direction of clinical research, which I've tried and have been relatively ineffective over the last 30 years, is to really investigate open versus closed reduction. As I've already alluded to the FAITH trial, it was barely 10% of patients had open reduction. So in my mind, that's the issue. If you have, I've done this many times through the years in training residents. We do a closed reduction, and that looks really, really good. Then we open the fracture, and you can see it's off 20 degrees in rotation. The fracture lines don't interdigitate. So you've got peaks and valleys on top of peaks and valleys, which is the reason why we get early settling of the fracture and the screws back out. This still needs to be investigated, because the failures, I'm sure, are primarily related to the fact that the reductions are not good. And you're relying on devices to hold the neck shaft angle and the anterior to posterior angulation. That's why in the FAITH trial for displaced fractures, sliding hip screws outperformed multiple screws, because you're transferring the biomechanical loads to the shaft. You're not relying on the screws to hold the reduction when they don't have any way to transfer the weight-bearing force to the shaft.
All right. Thanks so much for joining us.
My pleasure.